very much, and welcome to the traditional Thursday evening slot. As the title says, I want to bang on a bit about intracranial emergencies. And one of the first things that comes to mind is everybody says, oh, intracranial disease. You've got to see a neurologist, you've got to get a diagnosis, you need a brain scan. Well, it helps, but as far as the emergency case goes, it is completely or almost completely untrue. Most of the appropriate emergency treatment does not need a diagnosis necessarily, and it's certainly you need an animal that's stable before anaesthesia, if it's going to be anaesthetised, before brain scan. And so stabilising the patient is far, far more important as the initial stage relative to the diagnosis. And basically, any intracranial disease can be associated with emergency signs. And there's a whole long list. I'm sure you've got access to the slide later on, so I won't go all the way through them. Seizures are pretty important. But right at the bottom, weirdness and abnormal behaviour is quite a major component and may be the only sign, certainly, of some changes attributable to brain tumours in older patients, for example. So here, yeah, would you say that was an emergency? Yes, it might. It's been peppered with shot. None of those got anywhere close to the brain. The cranium in most dogs is pretty tough. I'd like to think that most dog bones or cranial bones are probably tougher and thicker than our own. You do get the odd exception of the chihuahuas with a persistent open fontanelle, which is a bit of a gap at the top of the skull where the bones don't close over as the dog matures. And occasionally all you have to do is tap the top of the skull and the dog will collapse with very mild concussion, only to get up shortly. And it can be a party piece for some dogs apparently, but we won't go there. This dog had absolutely no significant problems. It missed the eyes, didn't get to the brain. It was a bit sore, and it'll learn not to get in front of the guns, or rather the person shooting will probably learn not to fire indiscriminately when dogs are in immediate view of his gun. But what the hell. This was an intracranial emergency. Obviously it isn't anymore. And it's important because you don't have to be a neurologist to do this, but you do need some basic anatomy of the brain. So here we have forebrain, all this stuff all around here. This is the olfactory lobes. This is the hindbrain. The hindbrain here is a bit cerebellum, you can see there. And the important thing is the division here between fore and hindbrain. There's bone in that area. Okay. Now, if you were pretty up on this, you'd be able to identify that this particular dog had a meningitis. And what we have here is these are the roots of the optic nerves, and these are quite swollen. And this dog had distemper and died with acute distemper. A vaccinated dog. It was actually one of our nurses' dogs, and went downhill from normal to euthanasia, or progression requiring euthanasia, within about 12 hours. And these are the main signs of really swollen optic nerves, as with the main sign here. The other important thing is these structures, these are the oculomotor nerves, and they're coming out just at the junction of the hindbrain and the forebrain. And it's quite important. We'll come to those later. I would recommend that everybody, if you get the chance, open up a skull and take the brain out. You don't have to do it too delicately, but have a suss of where all the cranial nerves are coming out from. So you don't need to know and learn the precise anatomy, but some appreciation of fore and hindbrain, where exactly it is in relation to the skull, and relation to, for example, the ears, may help when you're localizing things later. But again, when it comes down to, you don't need to know that much brain anatomy. Dividing between fore and hindbrain is a massive area which will help you make adequate diagnosis and certainly guide treatments. Okay, here we have, I'll just put some pictures in at random because I need to take some time up to last the whole hour. And here we have an enhancing mass in the lower part of the brain. That's a pituitary tumour, and this dog was symptom-free. It had absolutely no signs. It wasn't even being MRI'd for this. We were looking at other changes in the cervical spine, and just managed to stretch up here. A completely symptom-free mass, and it's a big mass, but no clinical signs associated with intracranial disease whatsoever. Here we have, this was our first brain scan, God knows how many years ago, and it's useful, but for the purposes of this particular presentation, isn't necessary. Most of what we talk about here comes before brain scanning is required. So, basically, intracranial disease, let's talk about it a bit. The brain has really got very few components. Inside the skull, you've got brain tissue, you've got cerebrospinal fluid, and you've got blood. Yeah, there's a few other subdivisions of that, but that's about it. But basically, that's within an enclosed box. There are very few exits to the skull. There's the spinal cord comes out, optic nerves come out, there's other foramina that nerves come through, but they're pretty small and far between. So basically, if you've got any increase in volume of any of those brain tissues, you get some potential progressive change, ultimately leading to increased pressure. Because unless you've got a skull which is distensible, swelling of the brain will cause increased pressure. And if you want to try and maintain normal intracranial pressure, which would be a very good thing to do, if something's swelling, something else must be diminishing. And there is a degree of compensation that the brain can do to reduce the severity of any swelling, but that can be quite quickly exhausted, again leading to raised intracranial pressure. And the primary problem with that is it reduces blood flow to the brain. Blood flow to the brain is important primarily for providing oxygen, and we're going to bang on about oxygen quite a bit for the next hour or so. Interestingly, intracranial pressure does vary quite a bit anyway. If you cough, you increase your intrathoracic pressure. Abdominal straining increases pressure. Putting changes via the venous system, and you can get transient impairment of the venous return and build up a pressure within the brain like that. You can actually measure a pulse pressure wave if you look very closely with appropriate instrumentation. So there is a normal variation going on. And if you want to look on the converse, if you reduce the intracranial pressure, you don't tend to get many problems unless it's an acute drop. So sudden loss of intracranial pressure will damage blood vessel walls, leading to hemorrhage. But generalized low-grade or slow reduction in pressure isn't generally a problem. And as I demonstrated with that pituitary mass earlier on, the brain is actually a very plastic organism. It's really adaptable, much, much more so than was thought when I was a student. It can adapt to all sorts of things. Bits of brain can learn or develop completely different functions if other parts of the brain get damaged. And slow-growing masses can get quite large before they can produce any significant sign on occasion, depending where the mass is and so on. But our brains are remarkably adaptive organs, and we should give a lot more credit to that than, as they say, certainly we used to in the good old days. And let's come to the biggie, edema. Edema is one of the most significant causes of brain swelling. Two different types. We have vasogenic edema, which is primarily build-up of extracellular fluid, and this results from increased permeability of capillaries, usually associated with tumours, inflammatory foci, and hemorrhage. And often these changes will be surrounded by an area of extracellular fluid increase and edema around them. And quite often it's the build-up of the edema that causes the clinical signs, where the masses, particularly slow-growing tumours, may have been clinically dormant. Of just as great significance is cytotoxic edema, and this is associated with build-up of intracellular fluid. That happens to brain tissue under hypoxic conditions. So oxygen, really important. And if we get increased intracranial pressure, remember there are compensatory mechanisms. So if the brain swells, we can get reduced CSF production. Yeah, that will help for a bit. But we can also get reduced cerebral blood flow, which might be good at helping keep the pressure low, but it also means you've got reduced oxygen levels, which is potential an oops situation. So we keep talking about intracranial pressure. Can we measure it? Well, yes, we can. It's not easy. There are all sorts of devices which you can drill through the skull, put into brain tissue, put inside the dura, on top of the dura. They are quite fiddly, and they're great if your patient doesn't move around and doesn't change position, but they're very fiddly to use.